Well, thank you for the opportunity to speak today. And I think there are so many pathways to discuss and understand about age and aging, particularly in communities. With the work that I have done with non-majority population members, includes African Americans, Spanish-speaking people, and American Indian people. And I'm Oklahoma Choctaw and have been doing work on dementia in Indian country for at least 30 years now. And I think a broad cross-cutting theme with regard to aging and aging in communities is the need to understand community context. And community context means a whole variety of things. And I really appreciate, as I was signing on here, of hearing the 4 M's. And I think the portion of what matters really caught my ear, because I think that's where we begin to shift the focus in understanding from the patient's viewpoint, or from a family member's viewpoint, or from the larger cultural systems in a community. And I think it's really helpful to be able to elicit that kind of information, asking questions like, on the what matters, maybe including things that would be specific, like what do you think caused your condition, the complaint, whatever the presenting complaint might be. What do you think caused this? And what do you think is a good approach? Now, what do we do about this? And who's the best person to do it? And I'm borrowing from a psychiatrist named Arthur Kleinman and his concept of explanatory models. And the explanatory models notion is very much, I think, like the what matters, that particular M. And the ability to create an age-friendly community, or an age-friendly clinical type setting, all of that is based not only on being able to elicit from someone what matters and these issues about your perceptions and ideas about what caused this condition and about aging broadly. But it would be, if I were the clinician or a community health representative or someone heading up an aging program, is to understand myself what the larger meaning of this is. If somebody says something about what matters, I can intellectually write down a list of what they said. And yet, even more, if I actually understand the larger implications of those, the items on the list given by a patient or a family member, then I really can enhance the communication, the clinician patient communication, or the interventionist in a tribal community who has really good intentions and can ask questions, but the full understanding of that information is something that would be very helpful. And from somebody that's not a member of that culture, there is a task and a challenge to, over time at least, try to understand it better, more fully. And sometimes time is the only way to really get a best feeling for that. But you have to start somewhere. And so I think this kind of listening and elicitation from people and the observations, just the observations of the family, and hopefully people would be able to have a bigger picture beyond just one elder. And sometimes that means leaving the comfortable air conditioning of the office and going out into the community and even into a household. And I know that time pressures and equipment and things like that kind of operate against that. And yet it may be that there's a benefit to that that outweighs the cost, in a sense, of proceeding with that. So when we look at dementia in a community, and I will try to emphasize tribal communities, I think sometimes it seems overly simple. Maybe there's Indian Health Service, maybe, or maybe it's a tribe that operates its own health program, and people come in and seek care that way. And when there are when something is as complex as dementia, and it's many manifestations, it's multifactorial causation, and its expression symptomatically in a family and community really means that it's going to require a the concept of a complex problem requiring complex solutions. And here it may be that the actual neurological pathology is extremely complex, but the person is always going to experience this in a cultural context, and the family members would do the same in a cultural context. And so we have the need then for a variety of areas of expertise, but importantly, including the family and members of the community as part of that experiential expertise, I think really does help with a more comprehensive approach to helping this person experience what's going on with them. And as we know, of course, it's a progressive matter. And one of the things that I would borrow from the Savvy Caregiver program, and I was part of the team that led this team to develop the indigenized version of it, which we call the Savvy Caregiver for Indian Country. But a key part of it that Dr. Ken Hepburn, who was the lead on the team that developed the Savvy Caregiver program, he has as a central goal for the affected person to be able to experience more times of contented involvement. And contented involvement is two things operating together, but contentment in a person, sitting quietly in a corner all day that's okay. Contentment's good, but it's involvement, contented involvement. And he would point out, and the whole Savvy Caregiver for Indian Country points out, that with a progressive condition, the caregiver is challenged with needing to continually update their approach to helping this person have more time in the feeling of contented involvement. And so the awareness of this as a moving target is critical, and not just for the clinical community, but for the individual, the family, the caregivers. And when we expand this to a community, and imagine a person with not just memory loss, but confused thinking and disinhibition, and family members often don't want to take them out into a public setting or to a ceremony or a powwow or things like this because of the disinhibition, and it sometimes attracts attention. It can be embarrassing to others around them and their experience of that. And so the concept of an age-friendly community is one in which the community, the larger community, has an understanding of what the expressions, manifestations of this slowly changing ability and function to be able to operate normally being lost, and that it is not a stigmatizing condition. That's we should operate against it being perceived as a stigmatizing condition. And that's partly going to come from, I think, larger age programs outside of the household. The elder care program of a tribe, for example, can be part education. But I think one of the things we find in public health and community interventions and otherwise is that just education alone doesn't necessarily translate into behavior change. And so here we're not talking only about behavior change, but about a kind of conceptual change, a social perception change from stigmatized to not stigmatized. Now, so is that possible? And I think one of the evidence examples is that when we look at the DSM, the Diagnostic and Statistical Manual for Mental Health Conditions, over time, we observe that each edition has changes to it. And there was a time when alcoholism was a personal failing and weakness of will, and that has completely shifted over to a different kind of approach, more physiologically addicted and actual, in severe cases, brain changes. And so just to medicalize it or to make it an organic condition alone, I think, is not enough. We can also go back in the DSMs and find a time when homosexuality was a pathology, and actually in a lot of places illegal, and globally that still is a problem, but moved through time in the DSM up to the present, and that has significantly shifted. So I think these kinds of changes are possible, but here's where it sort of gets out of my area of expertise, and that is what we understand about community health, public health, population level health, is that the way of changing these conditions from stigmatized to non-stigmatized is going to be a kind of political and economic set of inputs. And by that, I mean that people in authority positions, which could include politicians, it could include tribal council members, whoever the leads are, the governors, the presidents, the chiefs of tribal communities. I think having those people on board for age-friendly, dementia-friendly, non-stigmatizing kinds of messages sent through tribal newspapers, tribal websites, maybe even special recognitions for families. And there are no magic bullets for this, except a kind of persistent and continual messaging that old age is not to be devalued. Old age with confused thinking is not to be devalued. And particularly the drive toward contented involvement, whether this person's at a local cafe or in a powwow, and maybe through some experiences or stimulation they're getting, begin to have symptoms that are, sort of maybe some kind of resistance to what is going on around them, and they're not able to do that. They're overstimulated perhaps at a ceremony or a powwow, or fatigue. So the expression of the symptoms that go along with confused thinking needs to be, by the larger community, understood as a situation where it is, and I'll use this kind of in a funny way, that is normal. And so what is normal for this affected person at that point in time? And what is normal in a sense over the progression and decline of the condition is what changes. And so a question is, so how do we begin this? How do we get the attention of policymakers, influencers, and actual, maybe even elected tribal officials about this? And I think one of the answers is that all of us have parents who are aging, and maybe given someone's age, have already walked on. That's certainly a possibility. But hopefully there would be some empathy and ability to say, oh yeah, my father, my mother, my uncle, or my aunt had age-related changes, but I still loved them. They still loved me. And we have this relationship, and aging changes become, maybe a better word is acceptable. And it's kind of strange to have to be even saying things like, we should be more empathetic. We should be more accepting of these changes. Why is it we even have to say these words or these admonitions? And that's where we come back to the larger societal culture in which elders are devalued. And people can say, we love our old people, I love my parents and all that stuff. And yet we can see a whole variety of markers and indicators and social and economic factors that suggest that older people, especially with dementia, are violating one of the central American cultural rules, values, norms. And that is what I call not just individualism, but hyper-individualism. We value hyper-individualism so much as a large American society that dependency becomes something that is just wrong. Yet dependency as in an adult is they lack individuality. They lack their own ability to pursue their own destinies. And when they can't do that, it's a kind of disability that goes against the whole system. And that's what caregivers say. Look, the system is built for people going to work. And, unless you're out on a yacht somewhere, and there are those people perhaps that are out on a yacht all day, every day. And we're kind of working for them. But the caregiver then has the experience of, I have to work to have money and have income. Then what happens to this elder who's now developing some dependencies? And I don't have an answer for that. And that's where elder programs, however, come in and that sort of thing. And the quality of care becomes something that maybe a support group, a caregiver support group could help with. And let me just mention this, as far as caregiver support groups, I think those are very helpful. And yet I'm going to suggest that answering the question, why do we have dementia support groups and the National Alzheimer's Association? And then there are some other smaller, large associations, but not like the Alzheimer's Association. And one of the answers to that in American culture has to do with what is called neolocal postmarital residence. And so here's what happens with our kinship system and our marriage system that's connected to dementia caregiving out here. And it is that in American culture, when two people get married, they move and establish their own household wherever their parents don't live. Now, that's called neolocal residence. I establish a new residence. Other parts of the world have marital residential patterns in which the bride or groom joins the other family's household and life place. And so it could be patrilocal or matrilocal. And the point here is that when those marriage systems happen, you actually gain people in the family in the same life space. With our system, you move away from parents. You take people away and establish this two-person household to begin with. Just we're talking in idealistic terms here. And that means as they age and have children, and those children get married and have neolocal residence, and they leave the parents, parents are still aging. Maybe one of them becomes, has developed some kind of dementia. And you have a single remaining spouse having to care for this person, not a household or a life group. And that is why I think we have these are artificial families called support groups. It's fictive kinship. And again, under these conditions of neolocal postmarital residence patterns, I think that helps to have these things called support groups. A group of people you've never met, maybe, and you all come together every week or month or whatever it might be. Now, in small communities, that's a little different in terms of knowing people. And at the same time, in small communities, conflicts, interpersonal conflicts can become and felt as very large. And yet, nonetheless, I think that family members can sort of step up to the plate and be able to be the support network, the primary support network. Nonetheless, it may be that a support group can be developed on a small scale, or depending on tribal size, on larger scales. So I think the summary for me overall for this is that I think this is a complex problem in many ways, dementia. I think it's a complex cultural problem because of these norms and values of individualism, and that the person can no longer operate individually. They are dependent. And that those are some of the areas that need to be addressed by the top of the community, the leadership of a community, and at the same time, with the educational opportunities about this condition for the community that is experiencing this, that has an elder person that is showing signs of dementia. And the understanding of what is causing the dementia is very important to find out. And how do we find out? We ask, what do you see as causing this? And teach me please, the larger part of this. And one of the ways that in interviews to elicit information is called the 5 whys. And by why, I mean WHY ? And asking that 5 different times helps the person and helps you drive explanations further and further back. So somebody says, well, you know, it's a brain disease and there's a bad protein. And at the same time, there's a lot of things. And you say, oh, why do you say protein? Well, they say, well, I read it in the newspaper. I say, okay, so why is it that you're using a newspaper for information? And you have to ask these in polite ways. It's not like you're critical or it's a test. But tell me more about the which newspaper? You talk tribal newspaper, or is that, yeah? And by the time you go, it's like, honest to God, it is like a 2-year-old. The strategy is like a 2-year-old who asks, why is the sky blue? And somebody, well, it's reflecting water. Why does it reflect water? Well, you get into some physics that nobody can answer after you get to the 5th why in this thing. So it is a helpful little tool to learn more about it. And you don't necessarily have to go to 5, but it really helps both parties in this communication. And when it's done in an interesting, sincerely interesting, exploratory way, often the person just sort of takes off on their own and begins to, oh yeah, yes. So that's one little tool to use. And I think that changes can be made in society, in communities, and in families. Changes toward the positive, changes toward reducing the degree of stigma, changes toward caregiver ability to recognize the progression and staging, in a sense, of this condition, and to learn how to optimally respond to the conditions that are being present now. And that's a hard thing to do. And here's my final thought about this for today, and look forward to discussion. And that is, if the affected person has more time, and I mean, it may be a moment, it may be 4 minutes, might be 17 minutes, but if more of those times of contented involvement occur, guess what? The caregiver is likewise able to take a breath, to have a moment of relaxation themselves, a sense of, I can't stop this progression, but I have responded well enough that I see there's much less agitation. There is much more cooperation, and actually helps both the affected person and the unaffected person who's trying their best to help out here. So